So the next speaker is Dr. Luquette, who I see is getting ready. So I'm going to start by introducing him. For some of you at the U, you don't really need much introduction for Dr. Luquette. But Dr. Luquette is a pediatric and perinatal pathologist, and he has a very strong background in basic sciences. He's very experienced, looking at all the bumps and things within the pediatric, gastrointestinal tract. So, Dr. Luquette, welcome.
Okay, good morning. The title of this talk is Familial or Not, How to Approach the GI Polyps. And actually, the answer to that question will pretty much be one slide. But there are quite a handful of little things that happen in a polypoid fashion in the GI tract, and that's what we're going to address today. Let's see if I can see this. Okay, so when we get polyps, they're generally going to come to us in a formalin, and it's the primary job of the pathologist in these cases to identify the polyp type. And once you put in your report what the polyp type is, if there are 3 or more polyps, then you add a comment. Given the number of polyps, a diagnosis of polyposis is warranted. Genetic counseling is advised. Now, sometimes it looks scholarly to list the different syndromes that the individual might have. If you have time to go into the chart and look all that up, but the baseline essentially is to properly identify the polyps and how many of them that you received. Also, it's good to look at the past medical record. Perhaps the individual had polyps removed previously or a family history, because if the patient has a family history of polyposis, a single polyp is going to put them in the category of needing some genetic counseling. Once you put the report out, the GI guys aren't going to necessarily try to figure the syndromes out either. They're going to pass the patient off to a genetic counselor. And those are the people that really work through the family history, whether or not molecular studies need to be done, looking for germline defects and those types of things. When you deal with the pediatric polyps, you can get it right probably 90% of the time, because about 90% of the pediatric polyps are juvenile polyps. And they do happen sporadically. So if you have 1 or 2 polyps, you may be in the sporadic category. Only the future will tell. However, if you have more than 3 or greater than 1 with a family history, then you're obliged to label the case as polyposis until proven otherwise. There's a variety of other types of polyps that children get. Hamartomas Polyps is just what it sounds like. A hamartoma is overgrowth of a local tissue. And I'll show you examples. We're going to go through a little bit of the text first, and then I'll show you examples of these different polyps. But basically, a hamartomatous polyp from the colon looks like a polyp made primarily of colonic tissue. Same thing for the small intestine. And as the stomach's concerned, more often than not, they look like foveolar hyperplasia. That's the part that goes hamartomatous most of the time. I'm not going to talk much about hyperplastic polyps. Most people in the adult world are familiar with them. They can be seen in the colon and sometimes at the GE junction and possibly related to reflux. Adenomatous polyps also happen in children, but while they can be sporadic in adults, when you see an adenomatous polyp in a child, it's assumed to be syndromic until proven otherwise. And probably in about 30 years of doing this, I've seen colon cancer in children 3 times or 4 times, and it's always been associated with familial adenomatous polyposis. Inflammatory polyps are interesting. They can look like whatever they want to look like. They're actually pseudopolyps, and they happen in a variety of situations in inflammatory bowel disease, infectious colitis, and sites of mucosal injury, anastomoses, strictures. And they often have hyperplastic epithelium, reactive epithelium, ulcers, inflammation, granulation tissue. And something that you don't see very often is lymphoid polyps, which are just a polypoid protrusion of lymphoid hyperplasia in a polypoid fashion. Now, in juvenile polyposis, the genes Most frequently found affected are SMAD4 and BMP-R1A, and they fall into different risk groups. Polyps that are at increased risk for cancer include juvenile polyposis coli, which involves the colon and the small bowel, and juvenile gastrointestinal polyposis, which adds the stomach as well. The low risk category is familial juvenile polyposis of the stomach, which are hyperplastic polyps in the stomach, and juvenile polyposis of infancy, which can involve the colon, stomach, and small bowel. Peutz-Jeghers is one that is popular, at least as board type questions and whatever, because you can match it up with the syndrome where you see perioral pigment. And it's quite interesting if you go and do a Google search on Peutz-Jeghers and click on the images, countless people have shown themselves in their hyperpigmentation, and it's very variable. It occurs around the mouth, on the lips, in the buccal mucosa. And the patterns are all unique, but it's fairly straightforward, very hyperpigmented black with specks and larger spots. So with Peutz-Jeghers, the affected genes STK11, also known as LKB1, and about 80 to 94% of the Peutz-Jeghers patients will have a defect in this gene. Peutz-Jeghers syndrome does carry an increased risk of cancer, and one of the hallmark features of the syndrome is the perioral pigment, as well as the gastrointestinal Hamartomas Polyps. And benign and malignant neoplasms fall into this syndrome as well from a variety of sites, including breast, pancreas, uterus, testes, and ovaries. The frequency of location that you'll find Peutz-Jeghers polyps, the majority are found in the jejunum, followed by the ileum, duodenum, colon, and the stomach. Low risk of cancer syndromes include some of the mixed polyposis syndromes, and these sometimes appear in children, but are usually more so found in adulthood, so I won't spend much time on these. And they all carry detailed phenotypes. So the Cronkite-Canada syndrome, patients present with alopecia, onychodystrophy, macular skin lesions, juvenile polyps in the colon, and hyperplastic polyps in the stomach. They also have a malabsorption and a protein-losing enteropathy. P10 Hamartoma syndromes, which affect the P10 gene, include Cowden syndrome and Banyan-Riley-Ruvalcaba. In the Cowden syndrome, they have multiple hamartoma neoplasia syndromes with all three germ layers involved. You get juvenile polyps and hyperplastic polyps in the entire GI tract from the mouth to the anus, neoplasms of the skin, thyroid, kidneys, uterus, and breast. Children present with intellectual disability, scrotal tongue, and progressive macrocephaly. They also get mucocutaneous tricholomomas, fibromas, plantar and palmar keratoses. And when I put this up, I thought to myself, scrotal tongue, what in the world is that? And who came up with that term? But just like with the perioral pigmentation, you can do a Google search on scrotal tongue, and there's people sticking their tongues out, showing you their scrotal tongue. And actually, it got that name because it's a pattern of fissuring on the tongue that resembles the skin on a scrotum. The other thing about the Cowden is, well, that's the other. Okay, then Banyan-Riley-Ruvalcaba presents with macrocephaly and lipomas, GI polyposis, hemangiomas, and pigmented penile macules, and they get juvenile polyps in the colon and hyperplastic polyps in the ileum and colon. Now this is, I don't know, this is in the way of the picture here, but it says 100% of familial polyposis. If there's a way to get that out of there. Yeah. It's right up here. Okay, thank you. So we were talking about polyposis syndromes and risk of cancer, and there's one category which is I'll refer to as absolute risk of cancer, which is familial adenomatous polyposis. 100% of affected patients will develop colorectal carcinoma if the colectomy is not done prior to middle age. And screening may not show polyps. You just may see foci of low-grade dysplasia. And I had a moment like this in my fellowship where I was called to the gross room to open a colon and prepare it for fixation. And I opened up this colon and it looked normal to me. And I just froze up. I said, oh my goodness, they took out the normal colon. And but I just proceeded and pinned it out. And the next day when I went to cut it in, I noticed that they had these slightest little dimples in the colon, but they were barely perceptible. And I still wasn't really convinced as to why they took this colon out. And it wasn't like nowadays where you just click in through the EMR or your anatomic path program. So looking at previous records wasn't quite as easy, but I cut the case in and I just took a lot of sections down the colon, and lo and behold, when the slides came out, absolutely every slide had multiple microscopic foci of dysplasia throughout the entire colon. And then I wiped the sweat off my forehead and said, oh, okay, this is a bad colon. They needed to get this one out. And then the previous showed that they had been following the patient, and multiple surveys had shown dysplasia over time. And it was a clearly thought out process. But not having encountered it before, it definitely put me on pause. In the classic picture that you see in the textbook, Adenomatous Polyposis coli looks like this. You get all these numerous little polyps all throughout the colon, but I've also shared a story with you about how it may look quite different. The adenomatous polyps are involved with or result of mutations in the Adenomatous Polyposis coli gene, or APC gene. And there are some variants of the syndrome, Gardner syndrome and Turcotte syndrome. And Gardner's is a good board question type thing because these patients have an association with osteomas and soft tissue tumors, lipomas, fibromas, and desmoids, and epidermal cysts. So familial adenomatous polyposis with osteomas and fibromas, good combination for a board question. Turcotte syndrome, the traditional version of it has APC mutations, and you get familial polyposis plus CNS tumors, namely medulloblastomas. But some people also include in Turcotte syndrome, because of this idea of ending up with cancer and having brain tumors, mixed match repair mutations that can lead to a non-polyposis colon cancer and CNS tumors. But in this case, the CNS tumors are glioblastomas instead of medulloblastomas. Now we're going to start to look at some polyps, and one of the challenges in photographing polyps is the lowest I can go on my scope is 2x. So you go through piles of polyps trying to find smaller ones so that you might be able to demonstrate them, but some of them you just have to shoot multiple fields to show them. And so this is a juvenile polyp, and we're starting out at the base of the polyp, and here you see the ink from where the stalk was inked, and this is a little bit of the stalk here. And when you go a little bit higher up, then one of the hallmark features in juvenile polyps is you get these large cystically dilated glands and a lot of inflammation in the interstitium. And then typically the surface of the glands is eroded. Often they won't have any surface epithelium, and it's replaced by granulation tissue and quite a lot of acute inflammation. And you have to keep in mind, all this inflammation can produce inflammatory changes in the mucosa. And sometimes you get glands that look a little bit like they could be adenomatous, but given that you're in this environment with quite a lot of inflammation, many people choose to look at these as reactive atypia. And again, it's one of those things that people have different thresholds or opinions on. Some people like to call mild dysplasia in juvenile polyps. Other people just like to regard it as reactive atypia. I have yet to see a juvenile polyp with a high-grade dysplasia, although it could happen. And as a pediatric pathologist, since I don't see much malignancy in the colon or whatever, if I ever, on occasion, when some of these glands get a little wilder and bother me, I always pass them by the adult guys who have a deeper experience with colonic mucosa gone bad. Now, when you get into Hamartomatous polyps, again, they look like where they came from. So this is a colonic Hamartomatous polyp, and it's composed primarily of colonic epithelium. Moving into the small intestine, this is a Hamartomatous polyp, and one of the other features of these is that they describe them as having a core that's got a lot of smooth muscle in it. It kind of arborizes and has this tree-like branching. And when you get to higher power down here, this is where the core is, and you can see the smooth muscle running through here, and there's quite a lot of it. And you can see some Paneth cells down here, and the mucosa, which appears to be small bowel mucosa. And then finally, hamartomas in the stomach, which the majority of them that you'll look at will be hard to distinguish necessarily as hamartomatous. You may say, oh, is this a hamartomatous polyp? Is this hyperplastic? Some terms even include polypoid foveolar hyperplasia. And sometimes you may end up backing down a little bit and calling it polypoid hyperplasia. We had a case like that once, but invariably it turned out to be a Peutz-Jeghers, because these guys are going to get worked up by the genetics folks, and they'll look for the genes. Or you don't get to see the patient if they don't put it in the history. You may not know that the patient has perioral pigmentation, and sometimes you can find that in the chart. This is just a higher power showing you the type of mucosa that's present. And then finally, adenomatous polyps, and they look like the adenomas, the tubular adenomas that you see every day in the adult world. And the histologic diagnosis of these is a challenge. And then these patients, if they're children, are going to be worked up for familial polyposis. Just a higher power showing you the adenomatous change. And then finally, fundic gland polyps, which are kind of interesting because this is one at low power. You can see it's about 2 millimeters across. And what you notice at low power are these little dilated glands in the middle of this body type mucosa. And I've gotten some of these things where you might find just one gland that looks like this, and everything else looks like entirely normal body type mucosa. And you get this thing and you go, this isn't a polyp. How could this be a polyp? This looks like normal mucosa. And then if you're lucky, you look around and you'll find one of these dilated glands and you go, oh, this is, it's a fundic gland polyp. And while these things are can be non-threatening, and adult type patients may be associated with PPIs, in children, they usually are part of a familial adenomatous polyposis, or at least you need to check that out if you find fundic gland polyps in children. And this is a higher power showing you these dilated glands in the middle of what looks like otherwise normal gastric mucosa. Now, inflammatory polyps can have a variety of appearances depending on the setting in which you find them. And this particular inflammatory polyp was a polypoid mass in an anastomotic site. It looks like a polypoid mass of granulation tissue with acute inflammation, or what you're more familiar with, pyogenic granuloma. And what you see is granulation tissue with a lot of acute inflammation. This is another inflammatory polyp, and this one occurred at a gastrostomy site. Here you can see the skin and this polypoid proliferation here. And at low power, it looks kind of spooky. These glands have a high nuclear cytoplasmic ratio, some gastric glands down here. This is a patient who kept pulling his G-tube out and really tore up the ostomy site and had to have another G-tube put in at another location. And at high power, you can see some antral glands down here, and this very reactive mucosa on the surface. And it really does add to the ambiance of it looking like a polyp, like that, you know, at first look, if you weren't aware, you might think it was some sort of a polyp that's not necessarily a reactive mucosa. And then here's a polypoid lesion that was removed at the GE junction. And I couldn't find hardly anything else in the chart to talk about it in terms of reflux or whatever, but this one just looked like a polypoid mass of squamous mucosa, and under higher power, you could see areas where there was some granulation tissue and acute inflammation and reactive changes in the mucosa. Now, inflammatory fibroid polyps were originally believed to be reactive lesions. And so they get this name inflammatory fibroid polyps, and it kind of makes you think like they're an inflammatory type polyp. And they do have inflammation in them. But it was eventually determined that these lesions had mutations in PDGF receptor A, and now that morphology is recognized with that. And these are generally adult polyps, and so I won't talk much about them. But there was a series with a review of the literature put out, and a small handful of children have been reported with inflammatory fibroid polyps. And then finally, I'm moving into cap polyposis. And the cap polyposis gets its name because it has this inflammatory cap on the top. And so here you see this purulent exudate, thick layer of it covering over or capping the polyp underneath which you see some inflamed granulation tissue. And this is a lower power. And the features of these polyps is they have these elongate glands. Some of them have a little bit of a serrated appearance to them. And then they have these dilated glands that fill up with mucus and exude a lot of mucus. And they also have intrusion of fibromuscular tissue into the interstitium. And that brings to this next topic about mucosal prolapse disorders, which I'm not going to get into a whole lot. And various people put various different types of polyps into this category. Villus architecture is seen in these, they get cystic dilatation, serrated morphology, and the hallmark is muscular intrusion into the lamina propria. And we don't see a lot of this in pediatrics, and mostly what I've seen over the years have been inflammatory cloacogenic polyps and solitary rectal ulcer syndrome. The inflammatory cloacogenic polyps happen down in the anal canal or rectal anal transition, and the solitary rectal ulcer syndrome in the rectum. And the thing that points you to these things is, number one, the location where you find them. But the other thing is the muscular intrusion. So if you get a polyp that's down in the anus, the GI doc's probably going to tell you he thinks that's what it is. But if you get one of these things and you look at it carefully, you may be able to see the smooth muscle layer in the muscularis mucosa have these tongues of smooth muscle that extend up off of the muscularis mucosa and intrude up into the lamina propria. So if you're trying to make this diagnosis of inflammatory cloacogenic polyp, pay attention to the location where you find it, and also this muscular intrusion, and then these other features. The solitary rectal ulcers sometimes look like sessile polyps. They almost look like serrated polyps, and they once again, they'll have this muscular intrusion that comes up into the lamina propria. Moving into some just a handful of odd things that you may find. Lymphoid polyps, I've never really seen a pedunculated one, but this one is sort of like a sessile aggregate with a cluster of lymphoid follicles. And some people call these rectal tonsils. And all it is a collection of reactive lymphoid follicles. Some other unusual polyps that you won't encounter very often. Here's a true umbilical polyp. And it's called a true umbilical polyp because you want to contrast it to not true umbilical polyps. And so these happen in the umbilicus. And here you can see the skin and this polypoid protrusion of intestinal mucosa. And this is just a remnant of the vitelline duct. And what you find most of the time when you get polyps from the umbilicus is just a polypoid granulation tissue, which gets some erosion and inflammation, and they refer to those as umbilical granulomas. And invariably, when you get the true polyps, that's also what they come to you, because these aren't very common. And so the surgeon will usually take off the umbilical lesion and say, hey, this is an umbilical granuloma. And every once in a while, it turns out to be one of these true polyps. Another odd lesion that's in the differential is a fibrous umbilical polyp. And these are not very common, but they don't look like granulation tissue. They look like a fibrous proliferation, and they have giant cells in them. If you go still in the GI tract, but to the extreme ends, here on the tongue, here you have this polypoid lesion, and it's got these giant cells, this sort of pyramidal giant cells in this fibrous tissue in this polypoid projection of the tongue. And this is the giant cell fibroma of the tongue. And again, you don't see very many of these. And if I can take the polypoid theme to the extreme, then we can talk about hairy black tongue. And this is an interesting thing to discuss just because of the difference in the pediatric category and what it means in the pediatric category. So hairy black tongue is actually sort of like a hyperplastic filiform papillae, and then they get coated with bacteria. So these villi that are on the surface of your tongue get larger and hyperplastic and covered with bacteria. And it's the bacteria that give the hairy black tongue its color. And it's not always black. Sometimes it's brown, sometimes it's yellow. And the way you treat it essentially is with a gentle exfoliation with a moistened gauze or whatever. You gently stroke it, and over time, you can clear it up. People try to attack it with all sorts of things, and that doesn't necessarily help too much. And unfortunately, what happens every once in a while in the pediatric age range is these things get biopsied. Invariably, this doesn't happen very often in kids. So the pediatrician will throw nystatin at it for a while, thinking it's fungal, and it doesn't go away. And eventually the pediatrician has the patient biopsied, and maybe the pediatric ENT might be unfamiliar with it as well and biopsy it. So it's a gross diagnosis. You don't want to biopsy these things. But it does sometimes happen in the pediatric arena because this so rarely happens in children. Here's an example of a case here. It's kind of hard to see down this kid's mouth, but there is this yellow discoloration of the tongue. And I shared this case with a pediatric dermatologist. And she said, yeah, that's just a black hairy tongue. It happens in kids, not very often. Please tell them not to take a piece out. And it's interesting how this thing came to me, because I got a tongue depressor I was called to the gross room to deal with this specimen, which was a tongue depressor in a jar, a piece of a tongue depressor in a jar. And so I took it over to the dissecting scope and looked at it. And I wish I had a camera on that scope, because I could have taken a picture of it. But it looked like these fine black hairs. And I'm familiar with the black hairy tongue. I've seen it before outside the pediatric population. So I thought to myself, I wonder if that's what it could be. And I made a sort of a diff quick mount of it. And these were these hairs, and under a higher power, it's not exactly easy to see in the photograph, but it looked like the bark of a tree. It had this shaft with kind of like scales on it, which were exfoliating squamous cells. And you could see loose squamous cells here and there and clusters of bacteria. And so, I signed out the case is consistent with black hairy tongue based on a gross interpretation of the dermatologist and what I saw under the scope. And of course, it sounds kind of gross, black hairy tongue. So, you can be nice to the patient and use these crazy medical terms, lingua villosa nigra. But and this is just a case that was reported in a 3-month-old, and they go through the whole discussion about how you want to be careful not to have these things biopsied. But to explain it to the general, the general physician population, you tell them, lingua villosa nigra, they go, what's that? But if you tell them black hairy tongue, they're going to go, oh yeah, I know what that is. So it's the opposite end of the spectrum, and then that's somewhat of a short talk, but it's really hard to. There's not, as I pointed out in the beginning, it's not a very challenging subject with these pediatric polyps, because 90% of them turn out to be juvenile polyps. And if it's something other than that, and you're confused about it, then it's time to hook up with a GI pathologist to get some help, and know that the gastroenterologists are always going to back you up and not let these things slip through the crack in terms of genetic counseling. Now, I know, Dr. Day, you said they're going to hold questions till the end, but we do have time. I don't know if you want to entertain questions now or.
Yeah, okay.